I gave this presentation to a meeting in Bologna, Italy, on the 16th of October 2025. This version shows exactly the same information, but in English. In the past 10 years, the European Union has not managed to collect sufficient plasma to meet the usage of immunoglobulin. This slide from the Market Research Bureau, an organization which collects data on the plasma industry, shows this clearly. It also suggests that this situation will continue and worsen in the future, as the rate of immunoglobulin usage is continuing to outstrip plasma collection. Self-sufficiency levels have stabilized at around 70 to 80% since 2021, meaning around one-fourth of immunoglobulin is imported from the United States. Note that these calculations assume a yield of 4.5 grams of immunoglobulin from each liter of plasma, which is fractionated. Any upwards or downwards adjustments in yield will have dramatic effects on the level of self-sufficiency, which in the current era is better considered as the level of strategic independence in this important product. It is important for the public health system to realize that these levels of strategic independence include a considerable volume of source plasma collected in the European Union from paid donors mobilized by the commercial sector. When removing commercial source plasma, self-sufficiency levels are much lower, at around 40 to 50% since 2020. Based on the usage of immunoglobulin experienced in 2024, an increase in the volume of plasma collected of around 3.5 million liters is needed. Hence, an increase of 36% over current collection volumes is required across the whole of the European Union to get to current levels of 100% self-sufficiency. Here we can see the average immunoglobulin consumption for several countries, estimated as grams per thousand population. Many of the countries outside the European Union use considerably higher volumes than the average usage in the European Union, and we need to expect that future usage in the European Union will rise and approach that seen in these countries. I now need to mention briefly the concept of latent therapeutic demand, which, in regard to immunoglobulin, is the amount of product needed if evidence-based practice is used in prescribing, and if usage is not constrained by any other issues, such as costs, lack of patient compliance, insufficient diagnosis, etc. This hypothetical concept is useful in predicting what the final usage of immunoglobulin may be expected to be for a given population. The estimation of latent therapeutic demand is done through statistical modeling using decision analysis. This is necessary as many of the variables used to build the statistical model are surrounded by uncertainty. With collaborators, we have performed many of these estimates, and on this slide you may see the results for the latent therapeutic demand for the commonest indications for immunoglobulin in the United States. Our models have been published and are available in the scientific literature. From this slide, I emphasize that the latent therapeutic demand for these indications already exceeds substantially the total usage of immunoglobulin in Europe. Hence, we should not be surprised that usage keeps increasing as the constraints around supply are overcome and usage approaches the latent therapeutic demand. I will now address the possible models for arrangement of plasma and fractionation in Europe. In this context, I will draw on work which we did during the supply project, which has been published and is available in these papers as shown. I am indebted to my colleague Dr. Lenny von Bonsdorf for this slide. The system for the generation of plasma products from plasma of different origins comprises several contributors, which may interact in different ways. These contributors include domestically sourced plasma, which may be fractionated in the country of the plasma's origin to plasma-derived products for patients in that country of origin. The domestic plasma may also be sold to fractionators, acting within and outside the borders of the plasma's country of origin, while plasma-derived medicines produced from diverse countries and independently from the domestic plasma are sold to the public health system. Finally, mixed models would comprise domestic plasma, fractionated under contract to one or several fractionators, being used to produce plasma-derived products, with the open market drawing on products from several sources is used to augment the supply of domestically sourced products. The first type of model, where the domestic plasma is fractionated within the borders of a country and provides all that country's plasma product needs, is not found in Europe. It is arguable whether it is found anywhere in the world, as the United States is totally self-sufficient in its needs for plasma derivatives, but fractionation is also done outside its borders. Cuba has a system of self-sufficiency in plasma and plasma product developed as a result of economic restrictions, but it is not known if this system meets all of Cuba's needs. Some countries in the European Union are now embracing the second type of model, whereby their domestic plasma is sold to fractionators without any linkage of the resulting products to the public health system. These include the Czech Republic, Finland, and Sweden, countries which source all their plasma product needs from the open market, while collecting considerable volumes of plasma which is sold to commercial companies. The mixed model is used by a range of countries, shown in the bottom part of this slide. These countries all commission fractionation companies to generate plasma products from domestic plasma, with the products returning to the public health system. A number of variants of this model of contract fractionation are found, whereby contracts are awarded under tender systems or directly to a single fractionator. Additional needs are then met through purchase from the open market. I have been referring, as is usual in this field, to self-sufficiency, which nowadays is better referred to as strategic independence. I propose that we need to recognize that self-sufficiency in itself is not the goal of a program for the collection of plasma by a public health system. Rather, it is the development of a pathway whereby the collection of the plasma leads to the delivery of products to patients in that health system. A dramatic example of how one thing does not necessarily lead to another is the system in the Czech Republic, which has the highest collection of plasma relative to population in Europe. It is evident that this collection, which is all sold to the commercial sector, is not associated with adequate treatment for Czech patients, as we may see from the usage of immunoglobulin, which is all purchased from the open market. This usage is significantly lower than the average in the European Union. Therefore, any system needs to ensure that there is a pathway which benefits the patients in the community from which the plasma is collected. This slide summarizes the current Italian plasma fractionation landscape, whereby 4 separate consortia, including all the 20 Italian regions, are contributing plasma to contract fractionation agreements which involve all the major global plasma fractionators. This has led to a beneficial level of competition, helping to keep prices for the generation of the domestic immunoglobulin lower than the products available on the free market. And this steady growth in plasma collection is also shown on this slide, a remarkable achievement for the Italian blood system. I feel I should acknowledge another feature of the Italian system, which is unique in the world. Products manufactured in excess of the national needs are donated to countries where they are needed but are unavailable. Recently, these countries include Palestine, where products from Italian donors are saving the lives of patients in that martyred country. Italians should be very proud of this. A recent development in the European system is the tender introduced for Spain, whereby a system of separate tenders by the tenders of the 17 autonomous regions has now been replaced by one national competitive tender. Currently, only one designated fractionator, located in Spain, is operational. It is desirable that, like the Italian system, alternative fractionators are also operational for the purposes of contingency. We need to ask whether the public health systems can increase further the collection of plasma in Europe. I will mention just two current barriers. We need to streamline and practice evidence in regulatory procedures. And we need to avoid impediments to our national and regional efforts from trade barriers. You would be aware of the substantial fall in blood and plasma donations which occurred when the measures to defer donors resident in the United Kingdom were introduced nearly 30 years ago. In these past years, this measure has been rescinded by most of the blood collection and regulatory agencies globally. These include the Australian blood collection Lifeblood. The European Centre for Disease Control has referred to the risk model now in use by Lifeblood in its new guideline for the management of donors who have visited the United Kingdom as a contributor to a revised position on these potential donors. Despite this evolution in thinking, we see that agencies based in the member states of the European Union, such as the Italian and French agencies, have not revised their recommendations regarding these donors. The policy of the Australian collection agency Lifeblood was modified on the basis of scientific modelling of the risk posed by including donors from the United Kingdom. It was estimated that the risk of the clinical transmission of VCJD was increased by a vanishingly small amount. Once the measure was removed, donations increased by 8.4%. We need these kind of studies to guide our blood systems towards the benefit which can ensue by making regulations more effective of evidence. During our work for the supply project, we found that several countries were apprehensive that their support of domestically collected plasma would be in contravention of free trade considerations. This issue became important with the so-called Medisanus case in 2017, when the High Court of Slovenia ruled that any tender procurement criteria which showed preference for plasma derivatives sourced from domestic plasma were disallowed under European free trade provisions. This free trade pressure was experienced by the Australian system 20 years ago, when the United States demanded that Australian plasma for fractionation would be manufactured under open tender, with the implication that such plasma could be fractionated outside Australia. This was successfully disputed by the Australian government through a review of the system in 2006. The Australian government argued to the Global Free Trade Association that such an arrangement was not in Australia's national interest. We must hope that, in this difficult period, national considerations continue to outweigh purely commercial ones. I will now review some other aspects of the European plasma and fractionation system. The slide developed by my friend Dr. Paul Strangers shows that 30 years ago, a plethora of plasma fractionation plants were operating in Europe. and in this era, several of these plants were owned by the not-for-profit sector. Subsequently, privatization and industry consolidation shrank the number of these plants considerably. This situation in 2000 remains more or less reflective of today, except that Biotest has also been absorbed within Grifols. The sanguine CAF-DCF plant has had a somewhat troubled history and has been privatized to form Protea, which has now been absorbed in Intas, an Indian fractionator. Despite this consolidation, Europe still has the second highest plasma fractionation capacity globally, with 35% of current capacity globally being found within its borders. As of 2017, a considerable volume of plasma collected in the United States has been shipped to other countries. This included nearly 19 million liters of plasma fractionated in Europe as of that date, 2017. The globalized industry also results in products crossing national and continental borders. Hence, disruptions to such movements as occurred during the pandemic can have a profound effect on product availability and prices. I find this analysis by the Market Research Bureau again to be very interesting and instructive. It addresses the role of the origin of the plasma on the profitability of commercially derived products. Essentially, what the analysis concludes is that the sale of plasma recovered from donors outside the United States gives rise to higher profitability when the products derived from it are sold outside the United States. This is because not-for-profit blood systems tend to sell this plasma, which has a higher immunoglobulin content than plasma collected from the paid donor population of the United States, for prices which are lower than those for plasma collected commercially in the United States. Conversely, companies will lose money if they sell products from expensive plasma from the United States, from which they can extract lower amounts of immunoglobulin. They will lose money if they sell this in the lower paying parts of the world, such as the European Union. We conclude from this analysis that commercial product on the European Union market and other areas outside of the United States is likely to be derived by plasma collected by not-for-profit organizations. The issue of immunoglobulin price is fundamental to the economics of the plasma industry. Here we see some projections for these prices in different parts of the world, which was proposed 10 years ago. We are now aware that these projections underestimated substantially the yearly growth in price. Some countries outside Europe also offer the commercial companies prices which are higher than they get in Europe. Hence, the continued support of the collection and fractionation of domestic plasma, coupled with a supply chain which ensures that the products remain the property of the public health system, is essential if patient needs are to be protected from the vagaries of the commercial sector. And as I approach the end of this presentation, I would like to share some final reflections. It is clear that Europe is still dependent on plasma collected in the United States, and this dependence is increasing. We need to continue our work to decrease this dependence. Otherwise, our public health systems will continue to be dependent on an unstable supply chain for an essential class of medicines. Our work in the supply project suggests that a number of models are being used to this end, and we emphasize that the model of choice is dependent on national political and social factors, and hence no model is universally applicable. We note that Europe has a large capacity to fractionate plasma, which is able to absorb the higher volumes needed to approach higher strategic independence. However, if this plasma is treated simply as a low-price, tradable commodity with no effort to retain it within the public health supply chain for plasma products, a dangerous situation may arise whereby this plasma and its derived products may be lost to the European Union. We need to appreciate always that the product will follow the price, and with immunoglobulin prices rising globally, we have no guarantee that our plasma will serve our health systems unless we take active measures to ensure this. I wish to thank and acknowledge the contributions of my dear friends and colleagues, Dr. Leni von Bonsdorf of IPFA and Dr. Matthew Hochko of the Market Research Bureau for their kindness in providing me with information and much insight. And I am very grateful to Dr. Giuliano Grazzini and Dr. Rosaria Bonini for helping me to convey my thoughts in the glorious language of Dante, which I did when I presented this presentation in Italian. Here in this picture we are all together 10 years ago in the SIMTI Congress in Naples. The years go by, but love and friendship endure always.